Hello, and welcome to Cardiology on Call, a virtual series presented by the University of Pittsburgh and UPMC. Today's presentation features an exciting and much talked about topic. In honor of Women's Health Month, today's topic will focus on women's heart health. We are incredibly pleased to present a panel of women leaders and medical experts across the University of Pittsburgh Department of Medicine and UPMC Health System to discuss today's topic, engage in panel discussion, and answer audience questions. It is our distinct pleasure to introduce today's moderator, a medical leader both in research and clinical care in the Division of Cardiology, Dr. Katie Berlacher.
Morning, everyone. Thanks for coming. We are thrilled to be here. I'm going to take a second and introduce the awesome women that I get to serve on this panel with. But first, I'll tell you a little bit about me. As they were saying, I'm a cardiologist here at University of Pittsburgh Medical Center. I did all of my residency and fellowship training here after medical school at Ohio State. And I focus large portion of my practice on women's cardiology, which deals with all issues that relate to women, whether it's when they're young or when they're older, related to pregnancy or cardiac effects of breast cancer. I serve as the Associate Chief of Education for the Heart Vascular Institute, as well as the Cardiovascular Program Director for the Fellowship. And I oversee the Women's Heart Program, which is centered at McGee, but really expanded outside of the walls of McGee to a variety of other peripheral locations. And like I said, I am more excited to talk about the women that I am joined by this morning. So I'm going to have them introduce themselves, and then we'll get started with talking about women's heart disease. So Dr. Issa Davis, good morning. Welcome. Can you introduce yourselves?
Yes, good morning, everyone. Thank you for having me. My name is Dr. Issa Davis. I am an associate professor of medicine, clinical and translational science at the University of Pittsburgh and UPMC. I am a family physician by training, and I'm in the Division of General Internal Medicine at Montefiore, and also out at our MedPeds practice in Turtle Creek. Clinically, I am a primary care physician, so I see all patients from literally birth until the end of life and everything in between. But I have a particular interest in women's health, and so have been specializing in women's health from pregnancy and midlife and as they get older. I'm a physician researcher, and my research that I do is big scale on obesity and tobacco, but I've been focusing really on understanding risk factors for cardiovascular disease that occur in pregnancy. So things like obesity and high blood pressure, and how during pregnancy and gestational diabetes, and how that leads women to have cardiovascular disease later in life. I also study tobacco and very interested in treating tobacco in the inpatient setting and pre-surgical setting. And as we'll talk about, tobacco is a major risk factor for cardiovascular disease. So I am the director of the UPMC Tobacco Treatment Service. And I also have served on the American Heart Association, currently on the board in Pittsburgh and on the research committee nationally. And I'm also a member of the United States Preventative Services Task Force. And I guess I have to do my disclosure. Today's hat, I am not wearing that official hat. I'm speaking more as a physician and researcher, and not on behalf of the task force today. So nothing that I say should be attributed to them. Thank you.
Issa, thank you so much. I will say I get to interact with Issa's team on the inpatient service at Presbyterian, and her anti-smoking team is fantastic. So she has done a lot, as you have seen, but really leads the way in making things actually happen, rather than only speaking about them or reaching them. So really awesome work. Thank you so much, Issa. Dr. Malama Contreras, can you introduce yourselves for us?
Sure, I'd be happy to. My name is Dr. Malama Contouras. I'm a cardiologist at University of Pittsburgh Medical Center, and I am primarily based at McGee in our Women's Heart Center, and I also work at Presbyterian Hospital. My training started in undergrad at the University, at the Massachusetts Institute of Technology, and then I came to the University of Pittsburgh for my medical school residency and then cardiology fellowship training. So I now work as a cardiologist with with specialization in women's heart disease and heart health. I am also a clinician researcher like Dr. Davis, and I focus primarily on pregnancy complications and sort of link with future risk of cardiovascular disease and why that risk exists and what we can do to sort of prevent the development of heart disease in the future for women who do have pregnancy complications. Yeah, I think that's it. I think that's good.
I'm going to brag about you too, Malama, just a little bit, because Malama has also come up with a really innovative way to deliver care for patients, where she and a colleague of hers, Dr. Elise Hausberg, developed something called the Bridges Clinic, which really helps transition women from the postpartum state to chronic care with whether it's a primary care physician or cardiologist. So Mama, I just want to thank you for that. It's a really great opportunity for us to care for women with a maternal fetal medicine OB and a cardiologist at hand, so that we can safely deliver them back to people like Dr. Davis to take care of them long-term or keep them in our cardiology practice. So thank you for that awesome work, because it is truly terrific. All right, and last but not least, Dr. Elizabeth Picone, can you introduce yourself for us?
I'm Elizabeth Picone. I am a clinical cardiologist who works for the University of Pittsburgh Medical Center, HVI, the Heart and Vascular Institute. I've been a clinical cardiologist for 18 years now, and I also am a graduate of University of Pittsburgh Medical School. I spend my time in more rural and community settings, and I am very interested in access to care and caring for underserved populations. And I have a career-long interest in women's cardiovascular disease, both the underdiagnosis, under-recognition of these states. And it has been a privilege to work with my colleagues and really trying to interface, trying to get the people from out where I am into our major cities, and working with my colleagues to do that.
And I'm just going to take the opportunity to brag a little bit about Beth as well. Beth used to be doing a little bit of clinical time at McGee many years ago when I first started. So she served as a mentor to me for a couple of years. And then the need out in our northern communities and the rural community was so great that she really decided to serve primarily up there, and does a fantastic job of being our partner up there. And I want everybody to recognize that if you are seeing physicians outside of our central locations, potentially in Oakland, where Issa and Malama and I primarily serve, we worked regularly and hand in hand with leaders like Beth Picone, who are really necessary for us to provide care continuously when you return back to your home, rather than continue always coming into the city, which we know that not all of our patients enjoy. So Beth, thank you for all of the work that you have done up in North and that you will continue to do in the future. All right, so as you know, this has been a big topic of discussion in the media. So every single week, it feels like there is some article, there's some interview, there's some panel that is talking about women's heart disease, whether it's the risks that we have, the symptoms that we feel, the ways that we can mitigate those risks, other issues such as the disparities that women have, as well as the research that is going on. And for us, when we think about some of that research, we have seen, this is a picture of just a search for women's heart disease in our PubMed, which is like Google for our research articles. You can see over the past 2 decades, or 3 decades really, the research for women has really gone up and up and up. And this is awesome, because as you can tell, prior to 1990, there was very little research being done primarily on women's heart disease. So just a shout out to Dr. Issa Davis and Dr. Malama Contreras, who really help contribute to the research that we are producing. This is an awesome thing. We hope that we continue to increase in these numbers. And these are just some of the papers that we have been publishing, not us specifically, but that are there. They're talking about the sex differences. They're talking about physical fitness and the metabolic syndrome, as well as our risk. And so these are things that we really want to bring to you, to talk to you about today, so that you are aware of some of the things that we are learning. The goal here is also to tell you about the Women's Heart Program. As I was saying, it does exist primarily and centrally located at the Magee Women's Hospital, where both Malamo and I are, but it exists in a variety of other places too. And we take care of people throughout their lifespan. While Dr. Issa Davis takes care of infants, the rest of us do not, but we do start caring for women as soon as they are in really their late teens and beyond. We care for them during pregnancy, while they are getting chemo treatment and other treatment for breast cancer that has cardiac effects. We care for them in the pre, peri, and postmenopausal state, and also at the end of life. And all of these services are available throughout a wide variety of locations. If you are curious as to whether or not something is near you in the peripheral locations, please find us online and you can locate any of those doctors, such as Beth Picone up in the north, that you can see if you do not want to come down to Oakland. So with that, I'm just gonna start the first conversation for our panelists with the statement that cardiovascular disease is the #1 killer of women. It causes 1 out of 3 deaths every single year. There is over 43 million women who are affected by heart disease. And we thank all of our panelists today, though Dr. Davis does a fair amount of leadership in speaking for the American Heart Association, which has done a really terrific job over the past number of decades, getting the word out with the Go Red for Women program to increase the awareness for women about cardiovascular disease being the #1 killer of women. What we wanted to start discussing today is what some of the risk factors are. I'm going to leave this slide up for a moment, but I'm going to ask some of our panelists to start talking about specifically the risk factors that you see on the left-hand side, which are the traditional cardiovascular risk factors, something that we've been talking about for a long time, that apply to all of the population, that include things like diabetes, smoking, obesity, physical inactivity, hypertension, and dyslipidemia. So I guess let's start with Dr. Issa Davis. A lot of those things are familiar to you, I am sure, Issa, and things that you talk to your patients about. You want to choose one of them and tell us why it is a risk for us and for our patients?
Sure. May I choose 2 to start off? I was going to choose smoking and obesity.
Sure, let's go there.
Okay, there we go, smoking and obesity. So I'll start with smoking, because that is very close and dear to my heart, leading the tobacco treatment service. Smoking is one of those risk factors that actually before COVID over this past year was the #1 preventable cause of death. And it, now that we have a perspective on, over 500,000 people that we've lost with COVID just in a year, we tend to lose almost that amount, a little over 400,000 people to smoking every year, and it's preventable. It's a preventable cause of death, and it's the #1 risk factor for cardiovascular disease, and that includes stroke. And so it is linked to some of the other ones that we see there. Smoking will increase your blood pressure. It increases the risk of clotting in your blood vessels, that increase the risk of having a heart attack and having a stroke. It also will, the biggest thing is it's very difficult to quit, because it's very addictive, and probably one of the most addictive substances that is out there that's difficult to quit, but we can talk about some ways of doing that. The other thing that smoking will do is it increases, as most people probably know, it increases your risk of lung cancer and lung disease such as emphysema, as well as, again, increasing your risk of having a heart attack and stroke. Obesity is one of those risk factors that, for a long time we thought that obesity, and by obesity we mean, we really define it in terms of body mass index. And that is right there. Thank you for my slide. carrying too much fat on your body, right? And it's in addition to carrying too much fat on your body, it's where you carry that fat. And so the problem with obesity is you mostly carry that fat in your abdomen or in your belly, around your vital organs or in between your vital organs. And we know that fat has actually, it's very active. It has a lot of hormones and things that are happening in it. And those hormones and things that are going on in the fat can increase your, increase your blood pressure, increase your sugar levels, increase your cholesterol, and all of those things, are risk factors for heart disease, clogging of your arteries, increasing the risk of heart attack and stroke. And so obesity is one of those things, again, just like smoking was up there in terms of, kind of the second leading preventable cause of death when we think about the number of lives that obesity alone takes every year. Again, about 400,000. And again, we have now some concept of how many people that is. When we think about how many people have died from COVID, that's about how many people die from both obesity and tobacco every year. So I will stop there and let my other colleagues join in.
Thanks, Issa. And I think it's really important to highlight that those are two hard things that while we can control them, they are challenging to control, right? One is nicotine is addictive and obesity is hard to treat. And we all know that as individuals, and we all know that from our patients as well. Beth, do you want to comment a little bit? I'm going to flip back a little bit to this graph. Can you comment a little bit on hypertension, which I think is something that plagues many of our patients, as well as any of the cholesterol and other kind of common traditional risk factors that we have listed there?
Sure, Katie. So I think on the blood pressure end, and when we think about what blood pressure is, it's the force of the liquid, in this case blood, going through the tube that are arteries. So women are born with tubes that are smaller. And so it's very easy for women to develop high blood pressure, as opposed to having larger tubes and maybe a very tall male. And so I think women are born being more at risk for high blood pressure. And the reason that high blood pressure is considered the silent killer is because, quite frankly, unless your blood pressure is very high or very low, you may feel completely fine. But meanwhile, those pipes are taking a beating from the blood going through at too high of a pressure. And this causes a lot of long-term, 15, 20 years later, a lot of long-term organ damage on our kidneys, on our heart. Our heart has to strengthen and try to thicken to push against that force. It affects the blood vessels in our eyes and really is one of the leading causes of stroke in older women. And it is underdiagnosed, and again, under-recognized and underappreciated, because women are often told that they're nervous about being at the doctor and that their blood pressure is actually not elevated, when the majority of the time it's actually elevated. And so it's really an important risk factor that we all need to be aware of. It tends to affect people earlier on in life and be a chronic problem throughout their adult life.
Awesome. Thanks, Beth. When I talk to my patients, I always talk to them about numbers that they should know, and blood pressure is one number that they should always know. So if you're taking control of your health, blood pressure, you want to know that top number, which is called the systolic blood pressure, and the bottom number with the diastolic. You should know what your average blood pressure is constantly, so that you can help people take care of you and control some of these risk factors. The other thing I want to talk about quickly is diabetes. This is the second number you should know, which is your blood glucose. Diabetes, like hypertension and smoking, does increase your risk for cardiovascular disease. And the trick is here, the other bad news about this is that women who have diabetes are at greater risk for cardiovascular disease than men who have diabetes. So it's almost like a double whammy for us. It really stinks. And it's one of those things that we can control with diet, with exercise, and with medications. So if you don't know what your fasting blood sugar is, that's another thing you should talk to your primary care physician about. And then last but not least would be cholesterol. There's a lot of things that go into cholesterol. You get a total number, then you get an LDL, which is your bad cholesterol, and HDL, which is your good cholesterol, and then your triglycerides. And all of those things make up a picture of what your cholesterol is. The higher your cholesterol, specifically your LDL, but also your triglycerides, the increased risk that you have for developing cardiovascular disease in the future. So those are numbers that you should know. Again, your blood pressure, your glucose, your cholesterol numbers, and your BMI, as what Dr. Issa Davis was talking about. Those are things that if you don't know those now, make a list, a homework for you later on in the next couple months to determine what all those numbers are, so that then you can figure out what your risk for cardiovascular disease is. Well, I just want to thank everybody for talking about those traditional risk factors, and we're going to move on to what I think are a little bit more interesting because we have less research on, although newer data to suggest what some of those non-traditional risk factors are here on the right-hand side. This is an area that both Issa and Malama do a lot of research in, and so I'm going to talk to them mostly about what these areas are and why they increase our risk. Malama, I know you were talking a little bit about the risk of hypertensive disorders in pregnancy. Can you kick us off with hypertension in pregnancy and how that affects us down the line?
Sure, absolutely. As Katie said, there are a number of sort of risk factors that affect women primarily, and some of those we can identify during pregnancy. And part of the reason for that is pregnancy is like a natural stress test for women. There's a lot of hemodynamic changes during pregnancy. What that means is that we see changes in blood pressure, we see increases in heart rate, increases in cardiac output, meaning that the heart has to work a little bit harder in order to supply blood now to both mom and to baby. And so as women go through pregnancy, sometimes there can be sort of complications or things that develop during pregnancy that we have now shown are risk factors for heart disease in later life. One of those is under sort of the umbrella term of hypertensive disorders of pregnancy. And so that can include gestational hypertension, which is just high blood pressure that occurs during pregnancy. So we define that as occurring after 20 weeks of gestation. So something that develops only in pregnancy that you didn't have before. But it is elevated blood pressure greater than sort of Katie was talking about before with regular high blood pressure, a number that's greater than 140 on the top number or 90 on the bottom number. Classically, gestational hypertension is something that goes away when pregnancy is over. But we are now seeing that sometimes those high blood pressures that develop during pregnancy can last a little longer. And even more sort of severe form of hypertension in pregnancy is preeclampsia. And that is hallmarked by high blood pressure, plus we see sort of other organ involvement. And most commonly we define that as proteinuria or sort of protein leaking in the urine as a result of the preeclampsia. But we can see other organ involvement as well. Sometimes in the most severe cases, even women develop heart failure related to preeclampsia. And so now that we have studied big populations of women, we can actually look long-term and see if women have developed these complications in pregnancy, what does that mean for their future heart health? And we've actually shown that it does increase risk for heart disease. That would include heart failure, heart attacks, strokes, sometimes even in just the 10 to 15 years after delivery. So this gives us kind of a unique window to identify women who might be at risk in the future at the time of their pregnancy. So these are things that we're working on a lot at McGee, and we've really partnered with our obstetrics colleagues to help manage these patients, not just at the time of delivery, but actually more longitudinally. So in the months postpartum, to kind of address their high blood pressure, and then also for sort of their life course to make sure that we're really monitoring for risk factors for heart disease and kind of managing all of those risk factors appropriately.
Thanks, Malama. That's really helpful. And I think really important for a lot of our audience to know that even if they did have gestational hypertension and they were cured past pregnancy, that it's still something to talk about with your primary care provider at some point, because it portends risk greater down the line. Issa, do you want to talk a little bit about gestational diabetes? And even the other thing that's on the slide is preterm delivery. I can talk about that too, but I know that you study gestational diabetes. I'm curious what you found and what you tell patients about this.
Sure. So gestational diabetes is similar to what Malama just said in terms of gestational hypertension. So gestational diabetes is a diabetes or an increase in a woman's blood sugar that occurs during pregnancy. So we don't believe it exists prior to pregnancy. So it's not that she's coming into pregnancy with, having diabetes that wasn't diagnosed. This is women that were free of diabetes, came into pregnancy, and kind of around the mid-trimester, between the second and third trimester, starts to have and not be able to control her blood sugar. And then we do a test for diabetes during that time. And then we're able to diagnose women that have gestational diabetes. And we want to do that during that time because in the short term, gestational diabetes has increased problems for the mom at delivery. So oftentimes leads to either early delivery, so this preterm delivery, as Dr. Berlacher mentioned, where babies are born before 37 weeks or before term. It increases the risk of C-sections for these women, and mostly because, so one of the main things that happens with gestational diabetes is it ends up, the babies end up much, much bigger than they normally would. So a baby that's what we call large for their gestational age, for large for birth. And so oftentimes those babies have complicated deliveries and the mom ends up having C-sections. And then, kind of long-term, what we're learning is that gestational diabetes, which we believed at one point goes away, and it does appear to go, quote unquote, away after delivery of the baby and the placenta, and it kind of, women will go back to normal blood sugar. We're learning more and more that there are women that won't, and that will continue to have kind of this increase in their blood sugars or inability to get their blood sugars back to normal over that first year postpartum. And then women will have an increased risk of developing, quote unquote, type 2 diabetes, or what we think of as real diabetes, between that first year and up to the first 5 years after delivery. So it can significantly increase that transition from not having had diabetes to now having type 2 diabetes, which we talked about is one of the major risk factors for cardiovascular disease for women. And so there's a lot of interest now in understanding how better to screen for gestational diabetes. So we just conducted a large randomized controlled trial at McGee because there is thought that with our current testing strategy which is women come in and they they'll have to drink this really sugary drink. And if their numbers are above 130, then they usually go on to have a more detailed test, a 3-hour test. And then within that 3-hour test, if two of their numbers are positive, then we usually say that those women have gestational diabetes. Well, the thought is that with that current test, we may be missing some women who have also some level of abnormal blood sugar, but not to the level that test picks up currently. And so, but that women who have mild increase in their blood sugar may be at risk for having these bad pregnancy outcomes at delivery too. And so the thought was there's another test that we can do, a single test that may be picking up more women and help us to treat them, pick up those mild women, treat them, and then be able to lower those pregnancy complications. We just did a large randomized control trial and we randomized women to either the single test or the two-step test. And what we found was that that while the single test does increase more women being called to have gestational diabetes, more women identified as having an abnormality in their blood sugar, there was no difference in terms of the pregnancy outcomes, and the main outcome being the large baby, that there was no difference between the two tests. And there was another similar randomized control trial that recently came out as well, and concluded the same thing. So basically what that's saying is that our current test is still adequate to pick up the women who have gestational diabetes who would need to be treated to lower these outcomes, and that we need to continue to learn more in this field of identifying women, being able to then understand their risk, both in the short term during pregnancy, but also in the long terms in terms of their risk for cardiovascular disease. And one of the things, last point about gestational diabetes, of why we are seeing the increase in women having problems in pregnancy controlling their blood sugars, because of the increase in women who are coming into pregnancy overweight and obese, or because women are coming into pregnancy and gaining a lot of weight during pregnancy. So women who come into pregnancy normal weight, but leave pregnancy overweight or obese, and then by their next pregnancy, put themselves at increased risk of developing gestational diabetes and gestational hypertension for that matter. And so, dealing with all three of these problems during pregnancy and understanding women's risk is, like Malama said, is very, very important for us to help get women back to kind of their pre-pregnancy state, back to normal weights after pregnancy, back to normal blood pressure, back to normal blood sugar, is really important, so we can decrease this chance that they will continue to move on as they go on in life, to prevent long-term cardiovascular disease and complications. So I'll stop there.
Thanks, Issa. That was wonderful. And I think, what this slide and what Issa and Malama have really highlighted is the importance of chronic care. So not only care during pregnancy, but immediately after pregnancy, between pregnancies, and when you're done delivering or you're done having babies, that you still check in with your blood pressure, with your blood sugar, and that you mention these things to any physician that is taking care of you, as we all know that they are risk factors for later cardiovascular disease. I just want a couple things, and
Katie, can I say one more thing? I'm sorry,
because
I think it's something we should have. One thing I want people to keep in mind about the pregnancy piece is that normally when we talk about cardiovascular disease, right, and heart attacks and strokes, we're talking about older women, right? We're talking about women in their midlife, like 50s, 60s, and 70s, 80s. The thing that's so disturbing about pregnancy is we're talking about young women, right? Young women that should be at the prime and the health of it, right? They're 20 and they're 30s, right? And so I think we want to just keep that in mind as we continue to have the conversation, is that we're talking about young, what should be healthy women, right? And if we're setting the stage for disease in 20s and 30s, by the time they get to be 50s and 60s, we're actually shortening their life, right? Because they're going to develop this disease much, much sooner than they normally would. And, certainly can decrease their life expectancy. So I just wanted to throw that out there for people to keep in mind.
So important as we think about things that we can do, which we'll move on to some of the things that our audience can do in order to decrease some of their risk. Just real quickly, some of the other unique risk factors that oftentimes women, although some men also have, are breast cancer is obviously something that many more women than men have, and the treatment for breast cancer, both radiation and chemotherapy, increase the risk for cardiac disease. There are specific chemotherapies that are used that increase the risk for developing weakening of the heart or heart failure, and radiation does increase the amount of calcification in both our arteries and our valves as we think about heart disease for women. So if those are things that you have undergone, we are often thinking about from a cardiac standpoint, if you're at risk for developing any of the cardiac diseases listed here on the right-hand side. One of the other risk factors that that has been studied and been shown to increase cardiovascular disease is early menopause. As you all probably know, menopause is when you stop having your period and you have a loss of estrogen. estrogen, especially the estrogen that we make in our bodies, is good for our cardiovascular health. It's good for our vessels. It's good for our cholesterol. And when we lose the estrogen, we know that that's a time where heart disease increases, the risk of heart disease increases for women. So if you're going through early menopause, which is defined as before age 45, and even premature menopause, which is defined as before age 40, even more so with premature, you're at increased risk for cardiovascular disease. And that's something you really should be talking to your primary care physician about, or a cardiologist about, with regards to how to manage that risk moving forward. Unfortunately, it's not as easy as just giving you hormones. That has not panned out to be exactly the case, but it is a time to talk about what your blood pressure is, what your blood sugar is, what your weight is, what your physical activity is, and all those other sorts of things. Last but not least, if you have an autoimmune disease, so a lot of them are listed here, we know that those also increase the amount of cardiovascular disease seen later on in life. And the big picture thinking here is that the increase in inflammation throughout the body is what increases the risk for hardening of the arteries and the heart muscle, leading to many levels of heart disease, including heart attacks and heart failure later on in life. Let's get to what we can actually do about this. Beth, I know you spend a lot of time talking to your patients, not only about the risk, but more importantly about things that they can do. Maybe you can spend just a short period of time on things that we tell our patients in order to have optimal heart health.
I think it's really important when we talk to our patients, it can be completely overwhelming, right? To say, oh, you have to do X, Y, and Z. And so what I talk to my patients about is, what are you doing on a daily basis? Let's take a day in the life of patient X and tell me about when you eat, what types of food you eat, what choices you make. Do you smoke? I think echoing what Issa said, having the conversation and impressing upon females how much health benefit there is from stopping smoking is really important. Not just a conversation of stop smoking, but here's what you will gain if you're able to be successful. I think understanding simple things like, what is my weight related to my height? What is my blood pressure? And what simple things can I do? Like looking at lower salt diets. Do you understand what exercise means? A lot of people, you say, well, go exercise, and they're just completely like, does that mean I have to go to gym? I'm 60 years old, and how do I do this? And what do I do? And so having an open conversation about walking outside, walking on a non-graded surface, physical activity in the sense of doing what you can do, but doing it every day, and how it will build on itself the more that you do. And also empowering the patient that these are completely modifiable risk factors. If we empower ourselves, we can fix these things and we can live longer, better, healthier lives. And I think that's information that goes a long way with our female patients to know, hey, this isn't done to me. I can actually do something about this.
Thanks, Beth.
Can I just add
one
thing?
Yeah.
And I think that realizing too, because I know that a lot of people are doers and they want to like get in there and do it, and they want it to like change overnight. But I think the thing is setting steady goals, consistency, just doing a little bit every day, and just realize it's going to take time. But there's, so that in terms of weight loss, it's not realistic to just get out there and say, I want to lose 10 pounds in a month. It's not realistic and it's not healthy. So, I think, just as Beth said, set your goals, do a little bit every day, make changes, be consistent, and you will see the change over time. I mean, some of these will change much quicker than others. Something like weight does take time to change, and that's okay, as long as you're just slow and steady and you're doing it and you're noticing progress over time. So just setting realistic expectations too, and kind of, also is really important.
I think I agree 1000%. One of the biggest things that I see people do is they commit to exercise, right? I'm going to exercise. They go and they buy a really cute outfit and they get new shoes and they decide that they're going to go run, even though they've not exercised, but they're going to go run. And they go run for 5 minutes. They want to vomit. and they never go
and
exercise
then they're
again.
done.
And
That's
so
right.
we never want to set ourselves up for failure like that. You know, I think to echo what you say, realistic goals. It's okay just to go for a walk. Even if all you do is walk up and down your driveway a couple times to get started. Don't defeat yourself before you even get some momentum. So I think that's an incredibly important point.
Yeah, and I think I just want to highlight, you know, Issa and Beth, and I know Malama does this too, the importance of your relationship with your physician so that they set these realistic goals with you and that they work with you towards them, right? This is a long-term relationship that you have with your body as well as your physician, and you should find somebody that sticks with you, you know, and that's okay. You're going to fall off that horse, you're going to get right back on, you know, and we are here to hold your hand and cheerlead you, and, you know, celebrate the good things and you know, help you when you need a little bit of guidance back to the norm and exercise or stopping smoking, those things that we talked about that are really hard. We've got a couple minutes left here. Go ahead, Issa. You're about to say something.
No, go ahead. I'll do it on the Q&A.
Okay. All right. Sounds good.
And then.
I do want to talk a little bit about the symptoms of heart disease. There's a couple that are here. Malama, you talk about this a lot from a national standpoint. Can you tell me what you tell women when they say, what should I watch out for with regards to symptoms? If even if I do all of these things, sometimes symptoms develop. What are the ones that I should care about? And I've heard in the news that women develop different symptoms than men.
Yeah, and that's absolutely true. When we think about heart disease, I think the first thing that comes to everybody's mind is a heart attack. Our word for that in the medical world is a myocardial infarction, or MI. And for women, similar to men, the most common symptom is still going to be chest pain, chest tightness, chest pressure. You know, we hear about that like elephant sitting on your chest. And that is actually still going to be the most common sign of a heart attack. But women also can present with other symptoms, and that happens more commonly than it does with men. And so when we talk about atypical symptoms, we're talking about maybe it's shortness of breath, especially with activity. It could be pain actually that it may come from the chest, but it can radiate or even originate in the arm, specifically the left arm, or go up to the jaw into the neck. Sometimes we see with chest pain or alone, a nausea or vomiting or sort of diaphoresis, flushing in the face, and sweating, a kind of abnormal level of sweating. That can be, those also can be signs of a heart attack. So, you know, less commonly, but also we see it sometimes if you pass out or if you faint, that can be sort of a sign of an arrhythmia or of a heart attack. So, you know, like I said, I think that the take-home message is certainly if you're having chest pain, that is not to be ignored, but there may be other symptoms that could be signs of a heart attack. So if you're feeling something different, or if you're feeling symptoms specifically when you're exerting yourself, when you're trying to be more active, those are kind of red flags that they need to be discussed with your doctors.
Yeah, thanks, Mama. And such important information for our audience that's listening is if you note these symptoms, please make sure that you tell your physicians and that they listen to you, right? Sometimes they'll dismiss them, but you should at least get an answer for some, or at least try to get an answer for some of these symptoms. Sometimes we do look into this and we recognize that it's not, the chest pain that you have is actually not cardiac, and then we can do some other, you know, thinking with you to find the reason for that. But if you have any of these symptoms, especially as you start exercising or do any sort of activity, it's really important to talk about. I think what we'll do right now is just move on to the question and answer portion of this. I know there's a lot of audience members out there who've had some questions for our panelists. So Issa, Beth, and Malama, you can all take yourselves off mute, and we'll just kind of maybe chat more so about some of the things that we've been asked. So one of the biggest things that a lot of women might be thinking right now, or others that are listening, is how do I choose a cardiologist? How do I choose a physician? And we were just recently talking about this with regards to somebody that listens to you and having a relationship with somebody. But maybe Issa, when you are talking to your patients in the primary care setting, and you deem that they need a cardiologist, or you want to refer them to a cardiologist, how do you help them choose the best one to go to?
Yeah, so I obviously choose you all at McGee because you guys are fantastic, and I, try to get them to fantastic women physicians. So, part of it is I help them choose by, I do try to pay attention to the patient's personality and kind of how, what they feel that they need. Some patients, need a physician who's really going to sit and spend a lot of time with them. Some patients want to be able to, have their, questions answered and really be able to work with someone. So I try to think about personalities to some degree to match people up. So that's one thing I do. And then, also if they have specific heart issues, then I try to match them up with the cardiologist that may, have a little bit more specialty in that area. I mean, because even though you all are cardiologists, you do have your particular interests, like you all are interested in women's health. And so I know that you're going to have a particular, perspective that you're going to bring to those patients. So I would tend to match my patients up with you in that regard. And so, usually that's what I do. And I tell them that, and I give them some guidance on the things that they want to be able to talk about, questions they want to be able to ask, what to look for, in terms of a response. And I also will refer to cardiologists who are good about having a relationship with me, because one relationship is between the patient and the cardiologist. The other is between that cardiologist and the primary care, and being able to go back and forth and talk and be on, and co-manage the patient together. So I really appreciate, that dialogue back. And I know, Katie, you and I have shared a lot of patients together, and it's just so helpful, right, to be able to get that feedback back from you to know then what I need to reinforce on my end, with the patient, so the patient feels like they really have a full team around them.
Yeah, I think it's vital that we work with our primary care physicians and referring physicians, whether it's, sometimes Malama and I get OBs that refer patients to us. And other times we have, primary care physicians. I know, Beth, you work closely with all of the providers up in the kind of the north area. And a lot of they trust you more than they trust me necessarily, because they know you, they see you in the office, they see you in the grocery store, right? And so those are the important things to note, that exactly as Issa was saying, that we need to have a conversation and making sure that your doc is in good standing with the other physicians in the area. I wonder, Beth, if you can talk a moment about one of the questions that we're getting from the audience is about hormones. And we did talk about this a little bit as it relates to earlier premature menopause being an increased risk factor for cardiovascular disease. And I hinted that, unfortunately, the easy, quick answer that we thought, which would be, let's just give people hormones in a pill, and maybe that makes their heart health a little bit better. Talk to when you get questions about hormones from patients, should I take them for my heart health? Is it okay if I take them for hot flashes? How do you answer those questions from patients?
Well, I think I have a discussion that, like most things in medicine, there's gray areas, but it's not really simple one way or the other.
Right.
But initially, when there was a famous study, the Women's Health Initiative, and they had looked at women who were later in age, had already gone through menopause, over 10 years at least, and given them estrogen, and we had seen some bad outcomes. And so rather than sort of, I think, as physicians explain that to people, we really kind of put a black box on hormones, and all of a sudden the rates of hormone usage went down over 80%. And the flip side of that is there are a lot of women age 50, 59 who suffer significant side effects from menopause, including mood lability, sexual dysfunction. They can have significant hot flashes and what we call vasomotor symptoms, basically exactly like it sounds. You turn red and start sweating, and can have significant quality of life issues because of it. And if you actually look at it in these women, there may be a benefit to hormonal therapy, but there is very little risk. And so I have that conversation with them, and I tell them, I really think it's very important for people who are suffering quality of life issues and physical issues because of transition to menopause or perimenopausal state, that really, I think that hormones in the vast majority of cases, as long as you do not smoke, you're not have other risk factors, that and you're followed by a physician, that the answer of no, this is not good is really not the right answer. And I encourage women to advocate for themselves, You do not need an antipsychotic medication, an antidepressant medication. Sometimes you just need estrogen. And that's what I tell them. And I think there are very safe ways to help women through this area of their life.
Yeah, and I think the important part is that there's been a lot more data recently in the past couple of decades from the original studies that came out. The Women's Health Initiative actually were a big, cross on hormones because it increases your risk for cardiovascular disease. And the long and short of it is that the way that they did that study is actually not good and not representative of the use of a lot of the hormones, not only the type of hormone that we use, but the timing of hormone use nowadays. So if you do want to use hormones or curious about it, talk to your primary care physician, but also a cardiologist specifically who probably practices in women's cardiology, because not all are comfortable speaking about hormones. And I would say use it for a shorter period of time, as small a dose as possible. And there's some early evidence now that's suggesting that transdermal use of hormone is better than pills, although I think that's still kind of out there for us to decide as to that. But it's really important so that those symptoms go away so that you can have a normal life, right? If it's getting in the way of you sleeping and exercising, then those are the things that you need to do in order to keep your heart healthy. So, we really always need to have like the big picture view of these things. So Beth, thank you so much. It again highlights the importance of being able to talk to your physician. Malama, one of the questions that we're getting with regards to pregnancy is how long it takes for your heart to recover from the strain of pregnancy. I don't know. I know that's not an easy answer, but maybe you can kind of hint upon what you tell certain patients with regards to how long it takes to, get better or recover after you've delivered.
Yeah, I think that is such an interesting question. And I think it really is woman specific. So it really depends on each person individually. Everyone is going to be a little bit different in terms of how they recover in the postpartum period from pregnancy. If we're talking about someone that had a totally normal pregnancy and a normal delivery, it does take some time for the body to reequilibrate. We don't know exactly how much time, say, it takes the heart to return exactly back to normal, your heart rate, say, to return exactly back to normal. A lot of those changes do occur pretty fast, I would say, within the first couple weeks. And then, some of the changes and what Dr. Davis talked about in terms of weight, especially postpartum, may take a little bit longer. Breastfeeding actually tends to help with weight loss. And actually some studies show that breastfeeding even helps lower blood pressure postpartum. So I think breastfeeding, we talked about the benefits for baby, but there are also benefits for mom as well, which is really important. And now, for women who had, say high blood pressure in pregnancy or preeclampsia in pregnancy, this is something that we're studying. We don't actually know how long sort of those heart effects go on for. Some studies show that some of the effects take up to a year to renormalize, and some studies actually show, that we've done through collaboration with the McGee Women's Research Institute, show that it may take even longer, that these may be more permanent changes, some of them more subtle, but some thickening of the heart muscle that may persist even up to 10 years after delivery.
Thanks, Mama. And I wish we could easily say that it's 3 months after you deliver that, your body's back to normal. And that's just unfortunately not the case. For some women, it is. And for a lot of us, it is not. And so I think it's an important thing to be patient with your body. I think not only in the postpartum state, but also as it ages. We just, as Dr. Davis was saying, making change takes time and takes determination. You just kind of need to stick with it throughout. We're getting to the end of our session right now, so I'm going to give our panelists a couple seconds to gather their thoughts. I want you guys to leave our audience with kind of our last minute thoughts or messages for them. But as you guys are thinking of that, I just want to share one last screen here with them. A screen about useful websites. Okay, so if you're in the audience right now, I tend to think that the best way to see this is just get your phone out and take a picture of this slide if you possibly can. I know you don't have time to scribble down all those things, but if you take a picture, you can always go back. The Go Red for Women is the American Heart Association. The Choose My Plate is about nutrition choices, as well as the heart.org one is that slide where we showed simple 7 ways to improve your heart health. finding a normal BMI is our second to last one, and CardioSmart is something that the American College of Cardiology puts out for patients specifically. Lots of information on both the AHA and the ACC's websites about tips for patients, not only what to do to prevent disease, but also how to manage disease if you develop it, or if you have symptoms, how you want to look into those symptoms and finding physicians. With that, I am going to start with Dr. Davis. We'll do the same order. So Issa, if you want to leave us with a couple of words of wisdom for our audience.
Sure. So first of all, this was a wonderful discussion. Thank you again for having me. I want to leave us with the fact that, women, we tend to do so much to care for other people. And we play such a powerful role in that, right? We tend to be the ones that are overseeing our children's health, our partners or spouses' health, our parents' health. And so, and oftentimes in doing that, we tend to not focus on ourselves as much or give ourselves the same degree of attention that we give all the other members of our families and as well as and our communities, right? We tend to serve everybody else as well. And I just want to leave with that image of being on the plane, and they, go through that instruction at the beginning that you have to put on your mask first before you can help someone else put their mask on. And that and that oftentimes this is a marathon and not a sprint. And so it's so important right now for all of us to, and hopefully we've had a moment in the midst of COVID to sit back and realize just how precious life is and how quickly things can change. And that we've had a chance to really reflect on the importance of taking care of ourselves, both mentally and physically. And so I would just urge everyone to use this time as a reset to give themselves empathy and understand that we're all valuable and we need to take care of ourselves and to do that investment in yourself that you put so much in everyone else. And so I would encourage you to get a good doctor, get a good cardiologist, all those things that we listed in terms of the Life Simple Sevens of things they can do. Just pick one, start small, be consistent, and each day just get up positive about I'm doing this because I want to be my best self. I want to be as healthy as possible. Don't focus on how you look as much, but focus on the feeling fit and being mentally, sound and positive. So I leave you all with that. And thank you again for having me.
Thank you so much, Issa. It was great to have you. Malama, last thoughts for our audience?
Sure. I just sort of want to send a message of empowerment to tell women, feel empowered to talk with your doctors about any symptoms that you're having, and also to talk about your pregnancy history. So just sort of a final reminder that what happened during pregnancy is important, whether you're, 1 year after delivery or 25 years after delivery. So make sure you talk with your primary care physicians and your cardiologist about what happened in your pregnancies, and do feel empowered to tell them about any symptoms that you're having as well.
Thanks, Malama. Beth, last words for our audience.
I would just like to encourage everyone, don't be afraid of us. Whatever your symptoms are, please come. Don't feel like you have to be sick before you come and see us. We like to see people early, assess their risk, give them advice. Do not be afraid that we're going to think that you're crazy or have anxiety issues or what's going on is not real. Because honestly, those of us who work in these fields understand that often those particular symptoms are mimicking heart disease. And I always say men are sick and women are crazy for the exact same pathology. So please don't be afraid of us. We're happy to see people to just go over their health history and their things they can do in the future, and a risk factor modification visit. You don't actually have to have diagnosed heart issues to seek help from a cardiologist.
Thanks, Beth. And really important messages today to empower you to be an active participant in your own health, to ask questions, to seek care. If you're not ready to come to a cardiologist, talk to your primary care physician and see if they're ready to talk to a cardiologist about you. Those sorts of things. We are here for you. And really, I just want to last message for me is to thank our panelists today. You guys are awesome. And I thank you for carrying the torch to care for women and fight for women beside me, because it is awesome to work with other women like you. So congratulations. Thank you so much. And I believe Kelsey or Kara, I'm going to turn it back over to you.
Thank you, Dr. Berlacher, and Drs. Berlacher, Davis, and Picone and Contouris. Thank you so much for your participation today and for providing the audience with a wonderful presentation. Thank you to all of you in the audience as well for participating on today's Cardiology on Call event. We do hope that you enjoyed the presentation and learned something new. And as you heard today, we are so fortunate to have in our area excellent women leaders, not only in cardiac care, but in the entire spectrum of care of women, who lead with clinical excellence, research background, and most importantly, compassionate care. Should you have any questions about any of the topics today, or how you can help support the work that you learned about today, please feel free to contact us, and you can see right on here to contact Kelsey Sherbandi at the University of Pittsburgh and UPMC. In addition, you will receive more information and resources via email, along with a recording of our session from today. Thank you again. We do hope that you will join us for the next Cardiology on Call. Stay safe, stay healthy, and enjoy your day.